Good day to you. This is a presentation for the Irish Net Patient Network. My name is Bill Claxton, and I'm the president and co-founder of Carcinoid Neuroendocrine Tumor Society in Singapore. And yesterday, the 9th of November, I gave a presentation to your annual conference, and we did have some technical problems. So I had promised to make a recording of my presentation and share it with you. So here we go. Let's begin with my presentation. The title of my talk is A Cohort of One. We do make the journey with our caregivers and physicians, but ultimately it's up to us. We're on our own. And that's why we refer to the Cohort of One. I'll start the agenda with a review of my personal journey as a patient and then discuss various issues for newly diagnosed patients. I want to help explain changes in the treatment algorithm for NET cancer and discuss briefly how one goes about choosing a center of treatment, whether it's one of the centers of excellence for PRRT or another type of treatment. And finally, I have some concluding remarks. Now, I'm a group leader. CNET serves a community of patients throughout Southeast Asia. We have patients from Indonesia, Thailand, Malaysia, Philippines, Vietnam, some from India and China. What we do is we counsel, in particular, the newly diagnosed patients. We, as a group, offer seminars and online resources, and these seek to provide best practice for treatment, and also we help the newly diagnosed patients connect with specialist physicians who are focused on neuroendocrine cancer. Our group also provides aggregation of the voice of the patient, so we can speak up to pharmaceutical companies and even to government agencies, perhaps in support of orphan drugs or other initiatives. Now, my personal journey with neuroendocrine cancer began in 2004. I was diagnosed at surgery, and my surgeon reported that there were little bits of sand or little white microtumors spread throughout my abdomen, and he resected an ileal primary. This is coincidentally about the same week as Steve Jobs was treated for the first time for his neuroendocrine cancer. And I think it's instructive to compare the outcome for Steve versus my outcome. Steve had focused very much on his position in the world, in history, on doing the best for the consumers of Apple products and for his shareholders, and didn't pay so much attention to his disease. And so his medical outcome was not as good, and sadly we lost Steve last year. After my midgut primary was resected, I started looking around for targeted radiotherapy, and I tried initially in Australia, and eventually I connected with the physicians in Rotterdam at Erasmus Medical Center. And initially, I was ineligible. So you can see in the timeline below that I had disease progression, and for 3 years, I wasn't eligible for PRRT. The reason being that I had no large tumor in my liver. And when a 1 cm tumor was diagnosed via MRI in my liver, then I was accepted for PRRT therapy. Now, at that time, the PRRT therapy at Erasmus was done on the basis that everyone should have sizable tumors and everyone will receive the same treatment. The idea being that the researchers could publish papers on the effect of this treatment on progressive disease in a large cohort of patients who received the same treatment algorithm. So all of us received half a curie for 4 cycles. A total of 2 curies, which is a much larger dose than patients are now receiving when they go for PRRT. And in fact, it did remove all the small tumors, But there was symptoms returned in 2008 and 2009, and scans showed that there were some 2cm or 3cm tumors that were residual. And I was able to read these from the scans, copy them into a Word document, and identify 6 or 7 targets for surgery, and then find a surgeon who was willing to resect these tumors. One of them was in a particularly problematic area of the rectum. And so we had a team that consisted of a hepatobiliary surgeon and a colorectal surgeon. And we agreed on the treatment approach, and the idea being that we would not try to take out every cancer cell, but to just debulk the tumor as much as possible. This surgery was successful, and after that I had more or less complete remission. So my scans were clear and have remained clear except for a little bit of small recurring disease coming back more or less in the same places as cells were left behind from the large tumors. And my markers are still normal. Now, alongside my clinical journey is a psychological journey. Like most newly diagnosed cancer patients, initially I had ignorance and a lot of confusion about the disease. And then I started searching and researching here and there. I joined various online support groups. And eventually I started coming to some conclusions about what were the best treatment options. This is why I started going very soon for PRT therapy. And I also, over time, started to communicate with other support group folks, group leaders, and I learned how to become an e-patient, that is, to package all my medical records in such a way that I could send them to specialist physicians and get a second opinion. And eventually, I was able to coordinate amongst all the different disciplines of physicians, and I was a learned patient or a semi-professional. And that started my journey in advocacy, which led me to be a co-founder of CNETS here in Southeast Asia. So for the newly diagnosed, the first responders are typically the gastroenterologists. So the GI specialists have a very tough job because there are so many patients that they see for irritable bowel syndrome. IBS affects something like 20% of the general population. And what they've got to do is they've got to suspect the triad of symptoms which indicate the possibility of neuroendocrine cancer, and then do the appropriate tests, like a urinary 5-HIA or a chromogranin A blood test, in order to screen out the cancer patient from the rest of the IBS community. So surgery is kind of a later step, and it is the only potential cure. But the problem is that more than 50% of the patients are metastatic at diagnosis, and most have liver metastases, which qualify them as stage 4, meaning that they have distant metastases. And most oncologic surgeons will not operate on a stage 4 patient. Now this is wrong, because firstly, the correct approach is to get the primary tumor out regardless of whether there's liver metastases. And secondly, there's a lot of benefit in debulking surgery at various stages in the progression of the disease. Oncologists are kind of involved at a later stage, referred by surgeons, and often it's to prescribe octreotide. So this is a sad zebra because he's in that wait-and-see mode where he's on octreotide and been told that no further treatment can be offered until there's progression of the disease. Now, I want to share a few slides about basic understanding of neuroendocrine tumors. When we say neuroendocrine, we mean signaling pathways, as in neurotransmitters. And we also mean hormonal pathways, as in the hypersecretions that cause diarrhea and cause valve damage in the heart. Now, serotonin is the most active neurotransmitter in disorders. It's one of the most active neurotransmitters in the body, but it's especially associated with IBS, which, as I mentioned, affects a large percentage of the population. And it also is implicated in anxiety, obesity, hypertension, various vascular disorders, migraine, and nausea. But the most severe neuroendocrine disorder is actually NET cancer. Now, most NET cancer treatment options focus on the serotonin receptors, which are called 5-HT receptors, and these are expressed on the tumor cells. So, for example, octreotide, octreoscan, gallium-68 scan, and PRRT therapies are all about targeting the 5-HT receptors. Although the disease may arise in different organs, and you'll hear physicians talk about the difference between a pulmonary neuroendocrine, that is a lung primary, or a midgut primary, NET cancer is not really properly categorized based on the organ site, and certainly is wrong to characterize it on the stage of the disease. For example, a patient can be condemned to no surgical treatment as possible if they're stage 4. But this is not relevant to the treatment of NETs. The reason being, these tumors are largely indolent and slow-growing. And surgery is the preferred first-line therapy, even if there are liver mets. There are a number of studies that show that patients with advanced liver metastases benefit from removal of their primary. So how do we characterize neuroendocrine cancer? Firstly, is based on the grading or the proliferation rate. Low would be up to 2% mitotic cell count. Medium would be 2 to 20%. And high would be 20% and above. Most of the pancreatic neuroendocrine would be medium grade. And most of the midgut tumors will be low grade. And the highest grade are typically the rectal hindgut tumors. The other way we characterize neuroendocrine cancer is based on the biochemistry. That is, whether there are 5-HT receptors on the tumor cells and whether they have visible uptake on scans. Now, in order to manage the disease, several tests are important. The first is chromogranin A blood marker indicates a tumor burden, so it should be checked every 3 to 6 months. Second, the Ki-67 stain, it's a stain which is done on tissue sample, will indicate the proliferation rate of the disease. And this is really done only once, unless the disease becomes more aggressive. Functional imaging, such as octreoscan or gallium-68 PET-CT, is used to identify the primary lesions, to pick up whether 5-HT receptors are present, and therefore acts as a kind of screening test for the eligibility to PRRT. And also it's used to indicate if the tumors are still active after treatment. It's worth noting that the gallium-68 scan is so much better than the octreoscan at identifying primary lesions because it has about 10 times the resolution and can thus identify much smaller primary tumors. Now, if the disease becomes more aggressive over time, then a biopsy is called for to reassess the Ki-67. And also, it might be worth looking at an FDG PET-CT and compare it with other imaging. The FDG PET is a glucose-based scan, so it will highlight the very active tumors which are rapidly dividing, whereas the octreoscan or gallium-68 scan are looking at the indolent or slow-growing tumor cells. And by comparing these, one can know whether PRRT will be effective in treating the fast-growing cells as well as the slow-growing ones. For example, if there's a good overlap between the FDG PET scan and the gallium-68 PET scan, then you can use PRRT to target both. However, if there's not a good overlap, then the FDG PET is in a different place and has to be treated in different way, for example, with biologics or with chemo. Now, why does this happen? The tumor might be more aggressive because it's a different tumor. A second cancer has arisen spontaneously in the patient, or we don't quite understand the mechanism, but the tumor can, over time, mutate into a form which is more aggressive. So we have to always be on the lookout, and that's why having an FDG scan in addition to an octreotide or a gallium scan may be recommended. Now, once you know more or less what you're dealing with, then you have to assemble a team to cope with it. And in this diagram from Dr. Kjell Oberg at Uppsala, the patient is shown at the center with the oncologist, surgeon, nuclear medicine specialist, pathologist, endocrinologist, and gastroenterologist all around. Now, to some extent, this diagram isn't accurate because it doesn't reflect the role of the family caregiver, who often is very active, comes to every consultation session, and actually can help make decisions on behalf of the patient, often without pay and benefits, of course. The other thing is that with all these choices to be made and so many specialists, the patient and their caregiver will need a professional guidance. And I generally recommend the medical oncologist as a kind of team coach to coordinate the inputs from all the various members of the medical team and to help the patient make decisions about planning treatment. So I think that this diagram doesn't quite reflect that. If you are newly diagnosed and you need to assemble this team, you need to find professional advice, and perhaps the best professional advice is a medical oncologist who will lead the team. Now, rare cancers are multidisciplinary by nature. In this quote by Gilles Friedman, who is the founder of American Cancer Online Resource, or ACOR, he says that every patient with a rare cancer is going through a clinical trial with an N, or a count of 1, meaning they're the only ones who are going through the clinical trial. And this is why community support is so important. The patient needs to turn to somebody aside from the specialist physician for advice. And they find that they get the best emotional support from and coping tips from other patients. So they go online and they join various online support groups to get this additional support, which is most likely to help them in the long run. They will always be there 24/7, and they're peers that each patient can relate to. Now, when you decide on the treatment algorithm, you've got to then find doctors who are competent to perform the treatment. And generally this means travel. You have to go to a center of excellence, which has a multidisciplinary team, which follows consensus guidelines. And of course, you have to have contingency planning. For example, when you go for surgery, you should have the gallbladder removed, because if you're going to go on octreotide later, octreotide is known to cause gallstones. So as a contingency planning, we want to remove the gallbladder. Or if you're going for a surgery or a dental treatment, you want to have sandostatins or octreotide on standby so that in case there's a carcinoid crisis. So these are some of the contingency planning that you as a patient need to be thinking of. The good news is that you have time to plan your treatment because the disease is slow and indolent. And I always recommend consultation is a much better investment than treatment. So get plenty of advice before deciding on a particular treatment approach. Now, this is a therapeutic algorithm that many doctors refer to. It's designed by Kjell Oberg at Uppsala in Sweden. And there are a couple problems with this. If you look, surgery is the first line therapy, and for 70 to 80% of the patients who have indolent disease, sandostatin or octreotide is the second line therapy. And you can only progress to alternative therapies such as targeted radiation therapy as a third line. Now, since most of the patients are metastatic at diagnosis, they face the issue that surgeons don't want to operate on stage 4 cancer. So you've got to find an oncologic surgeon who recognizes the value of getting out the primary and debulking, say, the liver metastases. The second-line therapy also has problems because you're put in a wait-and-see mode with octreotide and perhaps escalating doses over time. And what are you waiting for? You're waiting for progression of the disease before you can go to PRT. But the problem with that is that all the studies of PRT show that actually it has the most benefit if it's done on patients with low tumor burden, small metastases, and before years of sandostatin analog therapy. In other words, patients who go on octreotide generally have dose escalation over time because the receptors don't take up as well. And if you have receptors which are not taking up as well, then the PRT is not as effective. So the PRT should be done earlier. That's why I recommend an alternative treatment algorithm to first locate and remove the primary and the large metastases. And second, use PRT to clean up all the distant metastases soon after the primary has been removed. And then go on octreotide or some antiproliferative therapy as a maintenance therapy. And at any time, you can loop back and you can do this process again, debulking, more PRT, and more maintenance therapy. Today, most PRT therapy is given with dosimetry, so the patient is not getting a very high dose. And therefore, there's really not an issue of facing their lifetime limit of radiation. They can keep going back and getting PRT for a 5th, a 6th time, and in some centers, they're practically giving it as a booster shot once a year. Now, when you're looking for a center of excellence, you should be looking towards Europe because the United States is really lagging behind. And this is due to the fact that Europe spends much more on medical technology and healthcare research than the United States. So the best centers are at Rotterdam and Uppsala, where I understand most of the Irish net patients go to. Also, there are centers in Bad Berka in Germany and Basel and Innsbruck, which are offering excellent care and personalized therapy, which is optimized for each patient. Now, in order to get in one of these centers, you've got to prepare your records in electronic form. So, how do you do this? You have to organize all your scans, keep the soft copy, ask them for a CD or whatever, get these files stored on a computer, organize them by date, and then copy them to a public site such as Dropbox, or put them onto a flash drive, a thumb drive, or a pen drive, whatever you call it. And then you can pass these files together with a open source reader. Now these files, the image files from scans, are of a common type called DICOM. So there are open source DICOM readers that you can download and you can include together with your scans, and then you can send off to, let's say, Rotterdam or to Bad Berka as your complete medical records and ask them for an opinion on whether you would be eligible for PRT or another treatment in their center. So the question arises, how do you choose which center of excellence to go to? Now, I understand that most of the Irish patients are initially diagnosed by their GI, and then they're participating in the national healthcare system, which will generally refer them to a specific center, most commonly to Uppsala or Erasmus in Rotterdam. But supposing you were able to choose, what criteria would you use? And so I want to go through with you some of these criteria that I think are important. First is, the site must have a web presence. Second, it must have a good reputation with other patients and with physicians. Third, and I think this one is really very important, is professional case management. They must respond to calls and emails. They must give you the information about what additional tests you need to perform in order to determine eligibility. The next most important is personalized care, whether the center is personalizing the therapy. And then less important is the cost of treatment. Now, most of the patients that I know are actually paying for their own treatment out of pocket. So cost of care is important, but it's not the most important factor. And then there's the question of accessibility. Let's say for an Asian patient to go all the way to Europe is a long way, long distance to travel. And finally, there are issues like whether the center offers holistic care. So let me quickly skim through some of these. In terms of web presence, the hospital or center must have pretty basic information in English about their therapies, particularly if they're offering PRT therapy. Also, other websites, like patient support group websites, must have information about this center. For example, describe patient experiences and have links to medical papers by the researchers who are working in this center to document what type of therapy is being offered and how effective it is. The reputation is important. Patients must feel the center is credible, and when you mention to your doctor, your physician must feel that they're willing to refer you to the center. And the peers in nuclear medicine and net cancer management must have a high regard for the center. That's why some of these centers have been recognized as Center of Excellence, and they have a kind of seal of approval. Now, this is the one that I think is a big issue, because some of these centers are so busy that they don't really reply promptly to emails. So a poor patient sends an email with some information about their medical condition and asks whether they might be eligible, for example, for PRT, and they don't even get a reply, which I think is quite sad. What the centers should do is they should reply right away and tell them what additional blood tests and scans are required before they can be admitted or considered. And then at each treatment cycle, there must be an exchange by email to indicate whether the blood tests are satisfactory. And then finally, at the very end, there must be follow-up to determine whether subsequent treatments are necessary or working, how the patients are faring 5 years out and 10 years out. This is all professional case management. Now, when we talk about personalized care, principally we're talking about things like dosimetry, so that radiation is given in the right dose for each patient. Also, they must have gallium-68 PET-CT because this is the highest quality scan available for neuroendocrine cancer. It's like 10 times better than Octreoscan. And they should also have FDG PET imaging to do a comparison in the case that there are more aggressive tumors, which may need to be treated separately. They should offer various isotopes. Most centers will offer lutetium-177, but the good centers will also offer yttrium-90. And sometimes they will stage it with initial dose of yttrium-90 and then follow-up doses of lutetium. Sometimes they will combine this targeted radiation therapy with biologics or chemo agents. For example, some offer PRT with capecitabine or interferon treatments. So this is all about personalized care. Now, the cost of treatment really varies. There are places in India where one can have a PRT therapy for as little as US $2,000. But on average, the initial treatment is around $10,000, and the recurring costs for each additional treatment are around $8,000. When we talk about accessibility, not all centers will accept foreign patients, and they may have different costs, different rate cards for local and foreign patients. You have to look at how far are they from an airport and how far that airport is from a regional hub or from the city where you live. So for Asian patients, they will have to travel, let's say, to Frankfurt and then to a smaller airport and then to one of these centers, which may be 25 kilometers away from this nearest city airport. Finally, some of the centers are offering holistic care. So for example, they'll advertise that they have good restaurants and hostels nearby so that your caregiver can stay. Or they may say they have museums and cultural centers nearby to see before or after treatment. There's alternative therapies in some centers, like Chinese medicine, massage, or Vedic therapy, and even music therapy. And most offer quality of life surveys, but some also offer psychological support and counseling. So this is kind of an emerging differentiation between some of the centers of excellence. The most important thing of all is for the patient to own their own disease. And this is where I feel that there's a big difference between patients like Steve Jobs and myself. Now, many hospitals practice patient-centered treatment, which means looking first at the needs of the patient and secondly at the standard of care. For example, if the patient just really cannot tolerate chemo, then the physician has to back off and try something else. With participatory medicine, not only are the patient needs central, but the patient themselves is involved in planning and follow-up. This might take the form of choosing physicians or selecting amongst various treatment options. For example, in my case, I worked with my surgeons to target specific tumors. So we had a written plan of action and we agreed whether we were going to go for an R0 resection or an R1 resection, meaning were we willing to leave behind some residual disease, which I thought made sense because there's always PRRT to clean up distant metastases, and you're never really going to get all of the cancer cells out of the body and out of the circulating tumors in the bloodstream and so on. So the decision that we made collectively was to go for a debulking of 6 or 7 specific tumors, and that worked very well for me. Now, we can't just see the patient as an abstraction. We have to see the patient as an individual, a person with their own desires and aspirations, their own pain and anguish. And as they go through the journey of owning their own disease, they will experience little triumphs along the way. And so as a group leader, we have to encourage the patient and give them, the feeling of strength through these triumphs and get them to think with their rational mind and not emotionally, because emotion is not going to solve any problem. Only practical thinking is going to make a difference in the outcome for the patient. So, in summary, patients are somewhat distrustful of physicians because of the common experience of delayed diagnosis and the unwillingness to wait and see. Medical tourism is a result of the need for multidisciplinary care and the emergence of centers of excellence. So the patient with a rare disease, whether neuroendocrine cancer or another rare disease, will by necessity have to find specialists of a multidisciplinary nature in some centers which are going to require travel, and thus they become medical tourists. Now, patients decide on which center, whether it's a PRT center or another type of center, based on its reputation, its case management, and the offering of personalized care. I believe that participatory medicine delivers better results, and that we really need to advocate for a change in the treatment algorithm. First-line care with surgery, second-line care with targeted radiotherapy to clean up distant metastases, and finally, octreotide or some similar antiproliferative to stabilize the patient, reduce symptoms, and prevent disease recurrence. So that's about the end of the presentation. If you want more information about our group, you can visit cnets.org. And I just want to highlight that these are the patients who were with me in my cohort at Erasmus in 2007 and 2008. Most of them are doing very well, and all of them are smiling because they're getting the absolute best available care in the world. Every patient and their state of mind matters. So I want to conclude by wishing you well in Ireland and thank Terry O'Neill and the team for giving me this opportunity to make a presentation to you on my perspectives on the diagnosis and treatment of neuroendocrine cancer. Thank you all very much. Good day to you.